to introduce our next speaker, Francesco Fiorentino. He is. He's the CEO and lab director of Genome-wide. As you all know him, one of the key opinion leaders in PGS, PGD. We also will talk tonight in the session about PGS debates, but then we really, what Jean-Michel alluded to, the next phase of NIPT, going beyond the chromosomes 8 to 21 to looking at all chromosomes. And thank you very much for your presentation. Fantastic.
You're welcome. Good morning. So, okay. I was asked to talk about genome-wide screening, and it is a pleasure today to show the results of our study using the genome-wide analysis for NIPT samples. And this is the disclaimer, and go ahead. NIPT is a very well-established technique, and with a very high sensitivity and specificity, but there are some limitations. One of the limitations is related with the limited amount of information that we are able to obtain with the conventional screening. And specifically, we doesn't work? Yeah. It's very small. Specifically, what we will go to lose is the information coming from the other chromosomes that are not the common chromosomes that we screen, and from structural chromosomal abnormalities and mosaicism. And if you have a look on the prevalence of such kind of chromosomal abnormalities, this account about 17%. And specifically, there are deletions, unbalanced translocations, duplications, chromosomal markers, and other rare trisomies, and triploidies, and mosaicism that may be prenatally detected during the prenatal diagnosis, or we can find the risk at the end at birth is just a small part of these aneuploidies. If we also add the microdeletions, that is another level of screening, at the end the final risk will be about 99%. So we can wonder why we should not use genome-wide screening in place of common traditional NIPT, especially if we have the genome-wide data already in our sequencing data, and this is true if using and massively parallel sequencing approach. And one of the reason is related with the lack of prospective trials still, because we don't know if using this information, this may in a certain way affect the performance of the screening. And specifically, it can decrease the specificity because of the increasing number of fails positive. So there is a kind of risk of overdiagnosis with a higher number of false positive that may, in a certain way, affect the results and also make in trouble the geneticist when cancel the patients. So the aim of our study was to expand conventional screening using genome-wide analysis, and to assess if using more data in place of a traditional NIPT can improve first of all the sensitivity and keeping the same level of specificity. And this is the method we use a genome-wide analysis, offering to the patient undergoing to traditional NIPT. These are the technical details using the Illumina workflow with NESIX 550 and a rapid run module, and we targeted an increased number of sequences because in order to increase the resolution to detect also small chromosomal imbalance. And for the bioinformatic analysis, we performed with both the conventional cfDNA screening, just focusing only on the 5 chromosome, and for the other chromosome we use the algorithm published by and their colleagues in the European Journal of Human Genetics. And this is an important point of the follow-up. Chromosomal abnormal results were confirmed by RACGH and traditional karyotyping by both amniocentesis or CVS, although amniocentesis is the best sample to be followed up. And also for the normal results, we basically confirmed the results by a newborn physical examination. And this was followed up by telephones and recorded in internal database. This is the overview of the study. We enrolled 13,500 patients. 12,000 of them accepted to receive more information of genome-wide screening, and 1,500 of them were excluded because they refused to undergo to this study. And this is a breakdown on the formation of the pregnancy. That the maternal age was 35. And the mean gestational age was about 12 weeks. This is also the breakdown of the indication for NIPT for the patient that are being included in the study. As you can see here, there is also the category of low-risk patients that we named parental anxiety that account for a quarter of the patients that have been enrolled. And having a look on the results, with conventional screening, we detected 166 chromosomal abnormal pregnancies, and 151 of them have been confirmed by prenatal diagnosis and invasive prenatal diagnosis. With genome-wide screening, we detected the 96 chromosomal abnormal samples, and in 169 the results have been confirmed by invasive prenatal diagnosis, with 27 versus 15 of them that resulted fails positive. Having a look on the type of chromosomal abnormality that we have been detected, of course the most that were trisomy 21, and as you can see, all the other more or less about 10-15 of these cases were the other trisomies and sexual chromosome abnormalities and rare trisomies and structural chromosomal CMVs abnormalities. As you can see, more or less is the same numbers. So the frequency of the prevalence of this kind of the rest of the chromosomal abnormalities are more or less the same in all the categories. And so we have been able to detect with the common traditional genome cfDNA testing 89.3%. Of the chromosomal abnormalities that have been detected, and in 10.7% of the cases were not detected by traditional NIPT. In 7.4% of them, they were compatible with an ongoing pregnancy and can result in the birth of affected children. just showing now some example of the results. This is a deletion of 34 megabase that was detected on chromosome 5. That is on the left of the image. You can see the confirmation in RACGH in amniotic fluid. This was a 31 years old patient at 13 weeks of gestation. Indication for testing it was parental anxiety. And this is another pathological results that we detected because of the genome-wide screening involving the chromosome 18. That is one of the chromosome involved in that we currently screen with the 5 chromosome screening. As you can see here, with the genome-wide testing, we detected about 4 megabase deletion in the short arm of chromosome 18, and in the lower arm of chromosome 18, we detected 21 megabase deletion that will be confirmed by array CGH. And both deletions, although the number of sequences was reduced, the algorithm that we currently use for the 5 chromosome screening was unable to detect such kind of missing of sequences. These are 2 interesting cases, 2 patients that were unaware to be carrier of a balanced chromosomal translocation. These are the details of the translocation. And the first patient was 32 years old, 11 weeks of pregnancy. The other patient was 33 years old at 12 weeks of pregnancy. And in one translocation, the segments were enough big. In the other were very, very small, so those were challenging to be detected by genome-wide cfDNA screening. This is the results of the first examples. As you can see here, there is a duplication of chromosome 9 and another duplication of 15 megabase on the short arm of chromosome 7 that have been confirmed by array CGH. And in the other case that was more challenging, as you can see here, we have been able to detect with the genome-wide cfDNA screening a deletion of 11 megabase in the lower arm of chromosome 13, and even, as you can see here, this small peak, even a deletion of about, a duplication of about 2 megabase on chromosome 20. This is another duplication that was not detected by traditional screening. It was the duplication of the short arm of chromosome 18. Unfortunately, we don't have the confirmation by cytogenetics or RACGH. This is another duplication, 16 megabase on chromosome 11, confirmed by array CGH. Again, a deletion of chromosome X in the short arm of chromosome X that have been confirmed by array CGH. And we also have been able to detect microdeletion, the George syndrome, and this is the deletion that have been confirmed by array CGH. We are, with this method, we also have been able to detect low-level mosaicism. This was a case of a trisomy 9 that we detected in the genome-wide screening that was confirmed 20% mosaicism with the traditional karyotyping. And another case was on chromosome 22. The mosaicism was 16% level, and on another case was in a trisomy 7 mosaic at 4% level that was confirmed by traditional karyotyping. comparing the two data, the data coming from the conventional cfDNA screening and the one coming from the genome-wide screening, and considering the 12 cases, pregnancies that have been missed by conventional cfDNA screening as a false negative. As you can see here, there is the genome-wide screening has a statistically significant higher sensitivity as compared with the 5-chromosome screening, while keeping the specificity at the same level. So there is no a statistically significant increasing in the number of fails positive. That is the answer that we were expecting from this study. The performance were great, very, as you can see here with the genome-wide screening, and although with the rare aneuploidies and segmental imbalance, the positive predictive value is quite low as compared with the rest of the chromosomes. And a few words on rare trisomies. As you know, rare trisomies should be interpreted with caution, because, as I said, because of the risk of misdiagnosis, we expect that the most of them, they are confined to placental mosaicism, and some of them they've been identified to be not viable, so the pregnancy in a couple of weeks can miscarry. But we know that placental mosaicism carries a small but significant risk of some pregnancy complications that are listed here. So we may use in a certain way this kind of information, even if just a small number of them can arrive to be a true fetal mosaicism. This is a very recent paper that have been published by Prevalence group, and where the authors demonstrated that the rare trisomies are associated with an increased risk of feto-placental diseases. And if you can see here, this is a breakdown of the kind of feto-placental diseases that have been detected. But I would like to focus on this point. As you can see here, the normal pregnancies has a reduced ratio of fetal fraction versus the two fetal fraction, the aneuploid versus the fetal fraction that we detect from the fetal DNA. So this is meaning that we expect that there's a part of this DNA, aneuploid DNA, is restricted in the placenta. So this highlights the reason why these pregnancies were normal in place of the other pregnancies. And a summary of the study, so we can say that the genome-wide cfDNA testing resulted accurate in detect both common rare aneuploidies and segmental chromosomal abnormalities. The genome-wide test delivered an improved detection rate as compared with the traditional screening. 12 pregnancies with the clinically relevant chromosomal abnormalities would have been missed if only conventional NIPT has been performed, and no statistical significant increase in false positive results have been achieved. And I would go, that is to the end, because this is just, I would conclude that the study provided preliminary data towards the clinical utility of the genome-wide screening, and in my opinion, this test has the potential to improve the pregnancy management, not only as an increased sensitivity, but also provide information for rare aneuploidies that can be very useful for the pregnancy management. And this is for those of you that may be interested in this more details on this study, as this has been published in Prenatal Diagnosis in the last couple of months. Thank you so much for your attention.